Great. So I'm taking the first question. So the first question, thank you, is that we're often told that when post-menopause or in later life, migraine will become less frequent or disappear. Lots of people we hear from, this doesn't happen. Why is this? And is there now evidence suggesting that actually this reduction in later life isn't as prevalent anymore in people over 65?
Well, the evidence that migraine is reduced in later life is reproducible. So I don't think there's no suggestion that's not correct. But it's evident, it's population evidence. It doesn't say everyone. It simply says that the majority, it's perhaps up to 3/4 of people will lose their migraine by the time they get to their 60s. But that means, of course, a quarter still have it. And I've seen people in their 90s with migraine. It's not, it's not, they're not incompatible, if I could say that. If your experience is not the same as everybody else's, well, welcome to humanity, because there are tall people and there are short people. The why it happens, that's not terribly well understood. It's certainly true that the areas of the brain that are important in migraine tend to be affected, shall I say, adversely, but it's a sort of bizarre way of saying it, by diseases that happen as people age. So in general terms, in very general terms, people with migraine in later life tend to not to have other particularly degenerative brain diseases. I'm talking about Alzheimer's disease substantially. So yeah, I mean, the problem with any population data, if I say that migraine is most common at the age of 41, well, you have plenty of people on the line will be 51, and some of them will be 31, some will be 21, and some will be 61. The problem with any population data is all it tells you is about the majority. It doesn't tell you much about the individual. With that said, you learn things from populations about the broad biology.
Yeah, perfect. Thank you. That's really, yeah, great. The next question is how you can distinguish between medication overuse headache and a migraine attack.
Well, the two different concepts. Migraine attack has all the symptomatology of a migraine attack, and they're not incompatible in terms of occurring the problems occurring together. So let me start perhaps by saying that the way people define medication overuse headache at the moment is that you should have a certain number of headaches a month. The arbitrary decision was 15. And you should be taking a certain amount of acute medicine a month. The arbitrary position, for example, with a triptan like sumatriptan would be 10 a month, or with an opioid, codeine, for example, would be 10 days a month. They're entirely arbitrary. They're based on, again, population data. And the way they were derived, maybe it's useful to say this, is to look at a population of people who were taking, for example, 10 triptan days a month, and then having followed these populations up to see, well, the population of people who were taking 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, so on, and then follow them up for 12 months and see at what point, if there was any point where it was more likely, if you were doing it, if one was taking, say, 10 triptan days a month, that in 12 months' time, you'd have more headache, that headache frequency would increase. That's actually how the data were originally derived. So it's all population data. And the concept of medication overuse headache is that some of the acute medicines, triptans and opioids, like codeine, for example, can make the brain more likely, more susceptible to headache. That's the concept. Now, migraine itself, I don't have to tell an audience full of migraine sufferers what a migraine is. It's sort of carrying coals to Newcastle. It's in people with medication overuse problems, shall we put it that way, they can have migraine as the manifestation of the medication overuse problem. That's fine and dandy. When you look into the data and when you really look at this in any detail, if you take a group of people who are taking, say, a triptan 10 days a month, which is this line in the sand, and it is a line in the sand, then and you get them all to stop that, not more than about a third have a spectacular improvement. And if indeed you go somewhere and you look at a group of people who start taking, say, codeine or any opioid for the treatment of some other problem, joint disease is the obvious example, not all of them at all will end up with frequent headache. In fact, the smallest, about 10% do. But all of the ones that end up with frequent headache had migraine as well as the joint disease. So current thinking is that within the whole universe of people with migraine, say there's 100, I realize there's a billion, but let's say there's 100. Out of that universe, a percentage of them, and it's probably about a third, are susceptible to having their headache status made more frequent and worse with frequent medication abuse. And about 2/3, it doesn't make a blind bit of difference. They may get worse. It probably doesn't make them worse. It's for many, it's more likely to be a response to increased frequency. So I've got more migraine, therefore I take more medicine. Why would you not? Because you don't want to have your migraine. The problem is it's impossible to identify the groups. It's impossible to say in someone who says taking 10, keep using 10 because it's the line, taking 10 triptan days a month. It's impossible to say, and you've got 20 headache days. It's impossible to say how many of those are having an aggravation of their problem with the relatively frequent triptan use, or how many it just doesn't make a blind bit of difference. Okay, so there's an argument in the headache world about whether to have everyone who's, say, taking 10 days a month of triptan or 15 days a month of triptan to stop their triptan and see what happens, or whether you should, because if you're taking 10 days a month, you need to be on a preventive, whether you should start the preventive and then encourage someone to reduce therapy. When you look at the controlled trials that have been done, where people have been randomized to these choices, the outcome at a year is about the same. So not everyone would agree with what I'm saying in terms of what I'm about to say in terms of conclusion, but up to there, I was just talking about facts. My conclusion from that is there's no reason to ask people to stop a triptan necessarily and suffer. I used to think that was a good idea, but I don't think the evidence supports that. It's perfectly reasonable in the generality of things, and there'll be some exceptions, but in the generality of things, to get on with preventive treatment, because as we could see it, most preventive treatments, or a number of preventive treatments, are not affected by the triptan use. So you get on a preventive, and if the problem is you've got a lot of migraine that you're taking triptan for, then the number of migraines will reduce because the preventive treatment does that, and therefore you take less triptan and everyone's happy. And if that doesn't work out, then you could start asking the question whether the medication overuse is a problem. So there's quite a shift in the way of thinking that people are thinking about this. Now, not everyone would agree with the conclusion I just came to. There are still people, I think, who are of the view that you should stop everyone and start from there. My reading of the evidence is it doesn't support that, but I wouldn't get it. But it's still, this is an area that people discuss quite a lot. I'm sorry I went on a bit long about it, but it's actually quite complex. And people have gotten into this habit of saying medication overuse, stop, get a grip, go on. And the evidence for that is actually very poor.
No, thank you, Peter. It's, really interesting to hear your thoughts. It is really complex. It's a question I struggle to answer myself, so really interesting to hear your perspective. Last question from me before I pass you to Beth. So the next question is, we've got a few people asking actually, how the treatments that are meant for other conditions, so things like amitriptyline, propranolol, how do they actually help reduce migraine?
Yeah, so as you say, amitriptyline, propranolol is the index one. It's just discovered because so many people with hypertension also had migraine, and there's actually a general practitioner in the south of England that first noticed it, which is well done them. The older drugs are what the science people or pharmacologists, people who study drugs, describe as dirty, meaning that they're not. Of course, they're washed, and the government makes sure that they're clean. But that means that they do many things. So something like the propranolol, it's called a beta blocker. That means it's supposed to block a particular receptor called the beta receptor, adrenergic receptor. The detail doesn't matter so much, but it actually turns out it does a number of other things as well. Other targets. Amitriptyline, for example, affects at least 3 chemical systems in the brain, as an example. Topiramate, which some of you may have had, affects at least 5 different chemical systems in the brain. So they're considered messy because they do many, many things. That's why many of them are quite side effect prone, because it's not that because they've got this range of things that they do. It turns out that some of the other things they do interact with the head pain system and the mechanism involved in migraine, and that's why they turn out to be useful in migraine. It's you might say happenstance in a certain way, and the dirtier something is, the more likely it is it's going to pick something up. So amitriptyline is a very good example. It's a very messy drug, so it's not surprising when you think of all the messy things that it does that might help migraine. It's also not surprising when you think of all the messy things it does that's going to produce side effects. Topiramate's another great example of that. So it's the fact that they were developed in an era when all the detail of the mechanisms wasn't well known. Topiramate, for example, is a sugar background, and it was actually first developed as a diabetes drug. No one was thinking about epilepsy, no one was thinking about migraine. And the way companies sometimes do things a little bit in the old days, they used to take something that they develop and they'd put it into various models. So they put it in an epilepsy model and it worked, and it wasn't a terribly good sugar drug, although it was developed that. And that's why they went down there. That's why it first developed as an epilepsy drug. So it's the messiness and therefore the consequent side effect profile of the older drugs that is the basis for why they work.
Great, thank you. It's really interesting to hear that, actually, because we do get a lot of questions about why people have to try different preventive medications.
Well, that's policy.
Well. So yeah,
well, that's government policy. That's nice policy. It's a policy. It's a cost-saving policy. No one thinks it's anything else. For the modern drugs to have tried the older drugs, it's an interesting problem. There's no question that as the newer drugs get older, I think that eventually we'll see that policy is just going to die, but it'll take a while.
Yeah, no, it's it's great to hear that maybe one day in the future that might change.
Oh, well, for sure. Once those drugs come off patent, it'll change. No one thinks it's a policy because it's a good idea. It's a policy to save money. It's not like anyone. So there's no point hiding from it. And once they go off patent, and they're as cheap as triptans and cheap as propranolol, but no one's gonna argue about it. There'll come a time when things will be really different.
And actually, considering like the things about cost and medications, putting cost aside, would there ever be a scope to take a CGRP mAb with a GPANT? And also, what would the risks be if you were to take both of them?
Yeah, so that's being done in the in the US and to some lesser extent in the private market in the UK. The evidence that's been collected so far is there's been no problem. You don't cause any more side effects. You just control the breakthrough migraines. I think that there'll come a time when as you say, and it may be a bit sooner than entirely off patent. We'll have to see, but there'll come a time when that's what will happen. The concept is that the monoclonal blocks the CGRP pathway at a sort of basal level, but there's still some activation of migraine, and occasionally the levels will go up again, and you just need to plug the hole, so to speak, and the GPANTs do that, and that's something that's well on the road of people's thinking, and it doesn't seem to produce any problems.
So it sounds like they would work quite well in combination with each other then in bridging that kind of gap.
Oh, yes. Yeah, and there's other uses. Some folks will find that towards the end, if they're on a monthly injection, maybe towards the end they have a few more breakthrough attacks. Using a GPANT is a way to get around the breakthrough attacks. part of that is it's almost obvious. You see that the mechanism is a good mechanism because the monoclonal is blocking for most of the month. And if the effect's wearing off a little bit before the end of the month, then it's logical to use some CGRP targeted mechanism.
Yeah.
The 1 month thing is entirely arbitrary, as you probably understand. Not everyone, it's obviously not going to work for everybody in a month because there are tall people and short people, what we said before. So there's some where it's going to wear off. And for some, actually, I have patients where they prefer to take it every 5 weeks. It's funny how that sends the system into an absolute tailspin because if the system says you've got to take it every 4 weeks, I don't know, they insist, trying to convince the pharmacy that 5 weeks is better, sometimes sends them into a tailspin, which is kind of funny because it's cheaper and it works, but the rules can be very rigid.
Yeah, I have seen that actually. Actually, talking about the effectiveness of CGRP, for example, so we do get quite a few calls about people that have been on CGRPs for a while, so they've had the injections, but they're noticing that they're becoming less effective over time. Yeah. Is that something that is being seen as being common practice, or, and also does having that kind of enforced break make a difference to that?
We've certainly seen it, and I think that there's some real world data that's emerged that would say that's probably happens in up to 20% of folks taking a CGRP. Part of the problem with what I just said is that how systematic the data collection is. People who are happy don't write a lot. Well, some do, and it's very kind. If anyone of you've written me a nice letter, thank you very much. Sometimes people do. But actually, most people, you don't expect that. Most people who are happy don't say very much. They're just happy. They get on with their life. They do stuff they're interested in. That's great. They're productive. That's the beauty of people with living with migraine. If you control their disease, they're not layabouts. They just get on with their life. So you don't hear as often from people who are really well as you hear from people who aren't doing well, which is kind of what, that's what medicine's about. It's not a complaint. So to some extent, when I say about 20%, it's probably, it's maybe inflated to look at if you're looking at the whole population of people who get these medicines. But there's certainly a group of people for whom they seem to have less effect with time. I think it's likely that the disorder evolves a little bit. And it's not like the pharmacology, the doses, or the effect on the body changes, but rather the disease itself escapes the problem. And CGRP is not the entire answer to the problem. And there are several ways that people deal with that. They stop and restart. They stop and they swap to another monoclonal, stop and swap to an oral GPANT, for example. And with time, there'll be other treatments that are being developed where people will stop and they'll go on to other treatments. So one day maybe it'd be great if we understood why this happened, but we don't understand it.
Now that was my next question, actually, was just about why does it happen, but it sounds like there's not a lot of information for that at the moment.
You didn't even send me any of the questions, so I'm not cheating. It's a cold. It's what they call a cold call.
Yeah, it is a bit. So this is why we try and put you on the spot today, you see.
That's all right.
So it's one of those ones.
If I get too much on the spot, I can always pretend that there's a technical problem. It's a great thing with this sort of thing. If you're getting harassed, you can sort of pretend, oh, gee, something's wrong with Zoom, blah, blah, blah. It's it's a bit naughty, but you can do.
Yeah, but it does work.
It's a good strategy if you're talking to someone you don't want to talk to. But basically, I don't do that all the time. I want to get on record for saying that, but you get the occasional administrative call where you'd like administrative calls where you occasionally would prefer that things they just went away. Sorry for digressing.
That's all right. It's no problem. So kind of on that kind of CGRP element and the GPANT. So some people have asked that if a person has tried multiple different preventive medications, they've had several different CGRP MABs, they've had the GPANT, but they're not effective. What are the next steps in the pathway for patients where they're not responding to any of the more recent treatments?
Yeah. I'm going to go out on a limb here and say that I'm yet to see someone in my professional career. Maybe I can't count on. I don't have a handful of people where absolutely nothing works. I have to say that. I see a lot of people where things haven't been done properly. That's more common. So for just about everyone for which things apparently don't work, there's some other way forward. Sometimes the diagnosis has got problems, but there are or other things are intervening, and there are other ways. There are other ways forward. But you know, the answer, if someone said to me, I've tried everything, I've tried it properly, everything, and it doesn't work, what do I do now? Well, what do you want me to answer? I mean, if you tried everything, you already know the answer to the question. The answer is there's nothing you can do if you've tried everything. My reply is usually that most people haven't tried everything, certainly done properly. And you know, if what I just said is even if it's correct, let's put it there for a moment, then there's a new target, something called PACAP, or pituitary adenylate cyclase activating polypeptide. Sorry, the names are getting longer. What can you do? That's just announced their first positive study in a really good journal. Their next studies are ongoing. Well, I would like to hope we could bring one of those studies to the UK, and they'll be looking for people who failed other things, because there's no point trying to develop drugs for people who don't have, you know, who could respond to other things. That's just stupid. So drug development people at least have got into the idea that if you're going to develop a new drug, it has to be for people who've failed a number of previous preventives. So if everything has been tried, it might be dark today, but there is light coming. There are new things I know in trial, and there are new things I'm aware of on the drawing board. The business of fixing up and sorting out migraine therapy is not at all done.
Thank you,
Great. It's
Peter.
good to hear there's other things coming, isn't it, Oscar? But yeah,
I was going to say,
Oscar will
hopefully
Well,
quite encouraging to hear, hopefully, that,
but I realise it doesn't help today. It's pretty cold comfort. But however, I remember saying that when the CGRPs are being developed, and people would look at you like, oh, really? But, you know, what we've learned in the last, I don't know, 20 years or so, maybe a bit longer, is that the more you understand the disorder, the more you understand the biology and can pick up the targets, the better you, and be very specific about the targets, the better you're going to be able to do, the more you're going to be able to develop therapies. And more important, and as important, by being very specific about the targets, you can avoid the side effects that have plagued so many of the medicines in the past. So it's a pretty good time to be in the development business in this area.
100%. And actually, it's funny what you said right at the start. I said it literally today to someone on the helpline, that I'm yet to speak to someone who has tried all of the things, and there's nothing that's left for them. So yeah, there is some encouragement there.
Yeah, it's easy to it's basically
Yeah.
there's a lot of options. I think that, you know, the looking forward aspect is something that the Migraine Trust leans into. The Migraine Trust is the sponsor of a large international headache meeting every 2 years, the Migraine Trust International Symposium, to get people together to talk about looking forward. I think it's the trust does a lot of things. One of the important things it does is invest in looking forward through research.
Brilliant. So
I'm a trustee of the Migraine Trust, so I'm mercilessly promoting the
thank
trust.
you for the plugs.
But I just got a conflict of interest.
Thank you. No,
But I'm proud to be a trustee of the Migraine Trust. Actually, it's not a bad thing.
We're glad to have you as well. So moving away from medication then, so looking at, someone asked, how effective are devices compared to medicines in treating chronic migraines?
Yeah. We got a range of devices that one could potentially use. Some of them are actually, the data is pretty good, and we find them effective when we can get to use them. The NHS and NICE does not quite see devices. They don't quite see them the same way as they see medicines, which is a bit of a shame, because at the end of the day, whether you ingest something to change what's happening in the brain, or you stimulate to change what's happening in the brain, you're effectively changing the chemistry in the brain. You're going to the same sort of place. The biggest challenge for devices is you have to do them, meaning for most devices, say the transcutaneous magnetic stimulation, single pulse TMS. You have to do it. You have to do it 3 times a day, several times a day. It's quite time consuming. It's quite an investment in time. And when I've had a number of people over the years who find that device very useful when they use it regularly. We've got a new device that just came along, a device that effectively engages the normal pain mechanisms in the body. So there's a mechanism if you injure yourself, you move your limb away from the injury. If you're under threat, you reduce pain responses so you can run. It's what keeps soldiers going on battlefields and so on, called fight or flight response. And you can engage that with a device to put around your arm, and you turn on with an app on the phone. It engages that mechanism in the body. Can be quite useful for migraine, and there are randomized sham-controlled studies for those devices as examples. So they can be effective. They could be a bit difficult to get hold of in terms of funding, because the government's not seen it that way so far. That said, I hope over time we can get the nice people to see the light on neuromodulation, because it certainly offers a really distinct advantage in terms of adverse events, side effects. Most of the devices are more or less side effect free in the broader sense of the word, and that can be very helpful if you've got other illnesses, what people call comorbidities, where you need to avoid certain treatments. They can be very, very helpful. So yeah, I'm a bit of a fan of neuromodulation.
Yeah, thank you. Exactly. It's a more sort of natural, non-medical approach for people that it's just access, cost, things that that are barriers at the moment. Yeah.
Yep. That's right.
Perfect. Thank you. So, for those who have vestibular migraine, if we are aware of an attack coming on, is there anything we can do to prevent it developing, or anything which will shorten its duration of an attack other than taking acute medications? So I assume this is a question around how to sort of stop the dizziness, the vertigo symptoms developing.
Yeah, if your migraine's dominated by vertigo, or I shouldn't just do it like that. Vertigo is the illusory sense of movement, that is, that you feel that you're moving when you're actually not moving. Okay. If your migraine's dominated by that, some people would use the term vestibular migraine. I can see why they do. If you're having an attack of that, then there's no, in principle, mechanistic distinction between whether you've got light sensitivity warning you attack's coming or vertigo if you've got migraine, because the endpoint biology is more or less the same. There are randomized controlled trials that will show the triptans used for early in the treatment of a vestibular migraine attack will stop the attack. Our experience with monoclonals, for example, is they're just as likely to reduce frequency and severity of vestibular migraine as it is any other form of migraine. So in many ways, as we understand that disorder, it behaves much like vanilla migraine. You might say it's a bit of a focus of research work at the moment, certainly for us, to try and understand as much about the physiology, pathophysiology, the disorder itself, to understand how to advance with the therapies. But in general terms, if the diagnosis is accurate, I'm assuming that it is, then using drugs aimed at migraine will be helpful in people with vestibular migraine.
Perfect,
the little twist around that is that I should say that the drugs that are used that have anti-nauseant properties, simple things like prochlorperazine that are relatively easy to get hold, are going to be on average more useful because of the nausea component that's associated with vestibular migraine. It's quite prominent very often.
Perfect. Yeah, that's really helpful, and that little added bit as well, really helpful. Cool. We're halfway through, so thank you so much so far. It's been incredibly helpful. So, a quick question before I pass you back to Steph. So, are dissociative episodes a symptom of migraine? This is something that people talk to us quite every now and again. Is it a migraine symptom or not?
I wouldn't recognise dissociative things as as migrainous. That wouldn't be the first port of call for thinking. No.
Okay. Thank
Okay.
you.
That's great. Thank you. Actually, can I just go back to the vestibular question? Just one quick question. You said that the CGRP mAbs can help with vestibular migraine. Is that
Yep.
the same for the GPAM medications, or is there not
Yeah.
enough information on that yet?
Yeah, there's not enough. There's not definitive information on either, but yeah, broadly it is true of the GPADs too.
Okay. All right. Excellent. I think some people were just kind of curious as to whether that would
Sure.
have kind of a similar impact on the vestibular migraine as well. There is a question actually about hemiplegic migraine. So obviously there's symptoms like weakness and numbness and things. And someone's asked whether or not hemiplegic migraine could have a relationship or be associated with other neurological conditions similar to MS because of the potential for some people for hemiplegic migraine to kind of the symptoms to become permanent over time, so that permanent kind of weakness or numbness.
Well, there's no relationship between hemiplegic migraine and MS. There's no mechanistic relationship. There's no overlap in the biology, and if you've got hemiplegic migraine, you're no more likely to get MS, and if you've got MS, you're no more likely to get hemiplegic migraine. They're not linked concepts. And that's pretty clear. Some people, as you say, with hemiplegic migraine who've got frequent attacks never quite recover between attacks. They have some between worsening mild weakness or other symptomatology. I think so, they get a bad run, people with that problem. They're very often treated as though they're sort of crazy or given some label, which is not terribly helpful. I think that properly treated, they tend to, they almost invariably improve. And properly treated that could be difficult, but properly treated, they generally improve. So if you've got hemiplegic migraine, you don't have to worry about having MS.
Okay, all right, that's fabulous. And
Well,
you
MS means
mentioned
multiple sclerosis for people who don't spend their entire time thinking about neurologic
medical terms.
problems. Yeah, sorry.
That's all right, it's no problem. Actually, you spoke about comorbidities a little bit earlier. What are the most common comorbidities to kind of run alongside migraine?
So the best the best established comorbidities are anxiety and depression. If you've got an anxiety disorder this year now, then in the next 12 months, you've got a 6 times greater likelihood of having migraine than an age, sex, socioeconomically matched control. And if you've got migraine now, you're 6 times more likely to have some anxiety problem with the following 12 months. It's what's called odds ratio. So there's the two are linked. They're called comorbid, but you don't get migraine because you're anxious, and migraine doesn't give you an anxiety disorder, but the chemistry of the two things share, and it's this what's called amine chemistry in the brain. I don't have to sort of stating the obvious to say that someone who has two conditions, migraine and an anxiety problem, it's hard enough to cope with a migraine attack if you're absolutely in control of everything else, and much worse to cope with a migraine attack if you've got an anxiety disorder, because the anxiety disorder makes it difficult to cope with everything. That's the nature of anxiety disorders. The same thing for depression, although it's about a 3 times odds ratio, and again, it's thought to be amine chemistry. There's some association, I think it's more strongly demonstrated in the US, between obesity and migraine. I think that's slightly more complex, and there's a lot of sample size, you might say, sorry for the pun, in the US. There's a little bit of evidence, there's a little bit of suggestion around asthma. I think that's pretty weak. The big ones are anxiety disorders and depression. It's important to emphasize, and I'll emphasize it again, that it's not thought that migraine gives you major depression, or that major depression gives you migraine. It's simply thought that the chemistry of the two overlap, and you're more likely to have both, and the interaction is unhelpful, so to speak, because it's harder to cope with one problem if you've got another problem.
Yeah.
And they should be dealt with separately. If someone thinks they're going to fix your migraine up by making you happy, that's a really primitive idea. The best evidence for that probably is coming from the monoclonals, where in the generality of things, they don't affect them. You can take someone with a mood disorder and migraine, you give them a monoclonal, they get the headache settles down, but their mood disorder doesn't change.
It's really interesting, actually, to hear that. I think the anxiety is probably something we see quite a lot of on the
I'm sure.
helpline when it comes to migraine and anxiety. It's a big one. Yeah.
is.
We also, weirdly enough, we also get a lot of questions about histamine and migraine. Is there any information on or understanding of migraine and histamine, and whether or not antihistamines or low histamine diet can help with migraine frequency?
The chemical systems among the chemical systems in the brain that may well be involved in migraine, there's one in the brain that uses histamine that may have a role in migraine. Amitriptyline has an effect on blocking histamine receptors. Broadly speaking, if you interfere with histamine, it's not particularly useful in migraine. I'm unaware that there's a particular diet associated with changing histamine levels that alters migraine. I don't think of histamine as a huge player in migraine. I think it's a chemical that's involved in brain. It's in brain areas that get involved in migraine, but on its own, it's not regarded as a prime mover, you might say.
Perfect, thank you. So I've got 3 questions for you on CGRPs now. So the first one is asking why it's mandatory or recommended to have the break or the gap in the CGRP injections, usually after sort of 6 to 9 months.
Well, I don't think it's mandatory. I don't think NICE says it's mandatory. There might be a local rule in the area you live that's evolved that, but doesn't. Mandatory is a pretty strong word. I wouldn't use that. Why is it recommended? Well, not everyone recommends it. The only reason. So why would you do it? You do it because you were suspicious that the person. Suspicious is not the right word. You wanted to ensure the person taking the medicine didn't need it anymore, because of cost and potential side effects. Although there's nothing recognised in the long-term use of side effects. So that's why you might want to do it. The evidence is that, and it's been done systematically, because it's not done systematically in the UK because it's not a mandatory rule. It, however, has been done systematically in Germany, Italy, and Switzerland, because there were various mandatory rules, and so it's quite clear what happens if you stop these drugs at 12 months, for example. Then the majority of people, what do I mean by that? 3 out of 4 will have their attacks come back. If you then reinstate the drug, then the majority, what do I mean? 9 out of 10. So Swiss have done this very nicely. Will have the response come back again. They'll respond again. So the evidence is that most people at 12 months, for example, if they stop, will have their attacks come back. Now, you could argue that taking a break is not unreasonable because you can get back on it fairly quickly. You could argue that. I'm not here to prosecute that case. I think it's a discussion you have with the person who's doing the prescribing. I find it difficult sometimes. I've spent a career telling people that migraine's a dreadful problem, and it's dreadfully it's dreadful for people when they have attacks. It limits life. It restricts what you can plan. It's disabling when you have it. I've spent a long time telling people that. And sometimes I feel a bit weird if I say to them, well, I've got this awful, awful problem and you're on this treatment which is working. Why don't we stop it and see if you can have some awful attacks again, just to see? That sounds like fun. And when I say that to myself, I think, really? That sounds like fun? It doesn't sound like fun to me. So I think one should have a careful and thoughtful discussion with the prescriber about how bad your attacks are and how willing you are to chance your arm that they might come back, and then what the rescue plan is if they do, because 3 out of 4 times they will. So I think a person who's coming off, say, the injections needs an on-ramp, you know, without having to get into some stupid queue that's going to spend 6 months to get to the front of the queue. Seems to me that if the attacks return, it needs to be easy to get back on the treatment, almost like send an email and get a prescription, really simple. Otherwise, it's quite risky because the numbers aren't in your favour, and they've been done really carefully by the Germans and the Swiss and the Italians. They've all the data's crystal clear and constant across the populations it's been done. So I'm quite wary about having that discussion, I have to say.
Thank you. And yeah, thanks for pointing out that mandatory recommended, because you're right, that's so important, and actually having that discussion with your specialist.
I think it's better. Yeah, I'd call having the discussion mandatory. I wouldn't call stopping a mandatory.
Yeah,
rule.
exactly. Thank you. Sort of online with that. So do you have kind of any statistics or kind of what the expected reduction rate for CGRPs to be successful? And is it normal to, someone said, to have 4 to 6 days a month on this medication? I suppose that would depend on what it was prior, but what would you expect the sort of reduction rate to be? Yeah.
So if you look at even look at the trials and then look at what's called the real world experience afterwards, and it's pretty much held up. So what you'd expect is that about half people who take a monoclonal will have half their attacks go away. So the person who says they've got 6 would have had 12 before, half their days go away. They would have come from 12 to 6. That's why I think the percentages are useful, because you can put them in your own frame. So about half the people get half the attacks go away. About a third will have 3/4 of the attacks go away, and about 20% will have them stop altogether. About 2/3 of people will have about the 30% reduction. I think 30% is pretty wimpy, so I don't think about it very much, I have to say. I think if you think you've got a good treatment, then you need to be. I actually think people are happy start to get really happy when you start to drop down to about 75%, 3/4 of them are gone. Because that makes, if you've got 20 days a month and all of a sudden you've got 5, that's a lot of space, but that's a lot of chunk of change to get on with life. But whereas if you've got 20 days a month and now you've got 15, well, okay, fine. I mean, I'm sure that's nice to have 5 less, but it's not really a great achievement. We'd like to do better. They're the rough sort of numbers that you should expect. There's a little bit of a build up with time. If you look at this again, the Italians have done this very nicely. It's they've got very large. They've managed to organise their headache centres and do some quite nice things. And some of this emerged from COVID when it was a bit difficult to change things. So if you've had a reduction on the medicine, say at 6 months, about 20% of people will still have a further reduction over the following 6 months. So the whole game is not done in the first 6 months. That's why this sort of idea of mandatory blah, blah, blah at 6 months is a little bit silly, because it's pretty clear from nicely collected data that there are people who that the improvement will still continue. There's the idea that you can take a decision at 3 months is pretty edgy, I think, although NICE wants us to take relatively early decisions. I prefer to find a way to continue therapy at 3 months to try and to see whether the effect is whether any effect is going to build up.
Perfect. And it's so encouraging to hear as well. Thank you. It's really good to, understand. And then final question about CGRP, and then CGRP meds, and I'll pass you back to Steph. So someone said that they'd heard anecdotally that the CGRP medications are less effective in managing menstrually related migraines. Is there any evidence or data to suggest that? And also they asked as a follow-up, are contraceptive treatments safe to take with CGRP treatments?
So I missed the second part, but I'll come back to it. I'll just ask I'll answer the menstrual thing. The answer is there isn't any evidence that they're not any less effective in menstrually related migraine. From looking retrospectively in what we have, there are prospective studies that are getting going now to specifically ask the question, how effective are the GPANs in menstrually related migraine? And we'll have proper data on that probably in about 12 months. For the moment, there's no logic, there's no reason why they shouldn't work. They might have to use them a little bit differently. It's in something called short-term prophylaxis. So if you're menstruating, the hormonal changes that are occurring are associated with longer attacks. So what will probably be required is to take these medicines over several days around the attack, and what's called short-term prevention. And that's the thing that's being studied. So, if you take one on the first day and you don't take another, you might have the headache come back. But that's because the triggering, the biological mechanism is still active. So it's an important question. It's an area of particular interest. And I missed the second part of the question. I'm sorry.
Sorry, the second question was, can contraceptive treatments, so like the Mirena coil, the contraceptive pill, can they be taken alongside CGRP medications safely? Is there always interactions with them?
Yes. There's no drug interaction between these things and the Mirena in particular, or the oral contraceptives.
Perfect. Thank you.
Right. Lovely, that's great. I'm actually going to ask a question now just about migraine and stroke. So this is something we get asked quite a bit, actually. Is there any information about the link between migraine and stroke? And if there is an increased risk, but like say if you've got migraine, there's an increased risk of stroke, or if you've got a particular type of migraine, for example, what else can be done to mitigate that risk if a person's already following a healthy lifestyle, their blood pressure's fine, they exercise?
Okay. So broadly speaking, the data around migraine and stroke is for migraine with aura, typically the jagged little spot that starts and then grows, the migraine with aura, visual disturbance. Not blurring, I'm talking about flashing little jagged lines. The data are that there's a relative increase in stroke rates in migraine with aura by about, probably 3 or 4 times off a small base. So if you're looking at, say, a 30-year-old woman, you might have a stroke rate of about 2 per 100,000, and it may go up to maybe 6 per 100,000. For the 6, it's bad news. For the other, 99,994 people, it's not a big deal. So the risk, the absolute risk is small, and there's a small relative risk change. You already said some of the things. If you can make things worse substantially by smoking, it multiplies the risk by about 10. That's not a good number. And you can multiply it by more with high dose oral contraceptives. There's no real evidence for the lower dose oral contraceptive, all it was collecting the high dose, but say estrogen containing, I'm talking about oral contraceptives. So the person who doesn't smoke, this is a good thing in general terms for stroke, blood pressure, cholesterol, exercise, diet are all important. You can't change your family history. You get the cards you dealt with. You've got to deal with the cards that you have. The risk is very substantially less as you get older. So very, very reliable advice, which is relatively easy to follow, is to continue to acquire birthdays and try and get beyond 45, where the risk becomes much less. Most people seem to be quite happy with the advice to acquire more birthdays. I never met anyone who didn't want any more birthdays. Some people grumble about it, but the alternative to not having birthdays, well, that's having a wake. That's not much fun.
Yeah, that's true.
So seriously, as you get older, the risk paradoxically becomes somewhat less. You can't change whether you've got aura. So if you do have aura, if there's anything you can do straight out of the gate, stop smoking. And if you're overweight, lose some weight. If your blood pressure's up, for God's sake, get treated. Get on a cholesterol medicine. The healthy lifestyle. The other thing to say is if you've got migraine and migraine stealing days from you, it's not a good idea to lose less days out of your life because you're not going to get a special discount. So look after yourself.
Okay, fabulous. I'm just going to squeeze one very last question in because I'm just conscious of time. So
Sure.
this last question is, sometimes we get a call from someone, they might say they've got migraine with aura, it could be ocular
Yeah.
migraine or retinal migraine. What's the difference between those?
So retinal migraine, the idea is that the change that's happening, the migraine, the aura is happening actually in the eye, in the back of the eye, in the retina and the eyeball, so to speak. That is extremely rare. That is extremely rare as a problem. In a referral practice like mine, if I saw one person a year with retinal migraine, I'll be dancing around the place. That's a very, very rare problem. And when I talk to my eye doctor colleagues who are interested in migraine, it's the same thing. Very, very rare problem. True retinal migraine, which it's a question about whether that exists, whether in fact that thing that's happening in the retina with the sort of visual loss people are disturbing about is a local retinal problem, not a migraine problem at all. So if someone thinks they've got retinal migraine, they need to go see an eye doctor, an ophthalmologist, because the likelihood is it's not. And if it is, then they need a review by an ophthalmologist, by an eye doctor.
Okay, lovely. Makes sense. I knew retinal migraine was very rare. I don't think I've really spoken to anyone that truly has it, to be honest. But you'll be pleased to know that was the last question. So you're now off the hook. And I'm going to pass over to Debbie, who's going to do our close for us.
Carl, thank you for the questions, and thank you for everyone who came along. It's very kind of you to make the time. Thank you.
As it is for you, Peter, and we honestly can't thank you enough. This is a bumper managing your migraine session for us, so thank you. We know how valuable your time is, but also how much people get out of hearing from you, so thank you. There will be an evaluation going out into everybody's inbox, because if you could fill that in, it will really help us, because it helps us to know what sort of things that you're looking for as we come up to planning for next year. If anybody wants to do any fundraising for us, I'm sure Peter would echo my sentiments in encouraging you to do that. We are a very small organisation, so if you wanted to jump out of a plane or run a marathon, feel free to do so.
I'm not encouraging people to jump out of planes. I'm going to say that right now. Anything that where you can't injure yourself, I'm going to say that's a good idea. Or if you want to at any point lobby a local member to help the trust or for migraine research, that doesn't help. That hurts us. Helps us quite a lot. Bit of lobbying. When the elections come around, they're very susceptible to listen to people.
Yeah. Even though we've got a while to go, we would definitely still encourage you to do that. And
yeah, exactly.
Lots of new MPs. We're trying to make friends and influence people at the moment. So yes, as Peter says, that's a very good way to be able to support us. So thank you all very much. Thank you, Peter, and we look forward to seeing you again soon. Take care, everyone.
Thanks, everyone. Thank you very much.
Bye. Bye.